Morning everyone, this is Dr. Mohit Chaudhary, TransConnect July 2025, and today we'll be talking about a very dreaded complication in transfusion medicine, that is transfusion transmitted bacterial infection. And although the incidence of sepsis is not that common, but it is very dreadful and it may also lead to a patient ranging from a symptomatic, asymptomatic patient or a patient which will undergo a morbidity or a mortality because of this bacterial infection. So my topic will essentially cover the introduction, the history, what is the definition, the organism, what are the sources, the various components that are involved, the factors responsible, signs and symptoms, and a small brainstormer in the end. So whenever you have a patient of a transfusion reaction, you first thing you do is you divide it into whether it is within 24 hours, that is acute reaction, or from 24 hours onward, which is a delayed reaction. Very important symptoms to look into this is fever with chills, and it may or may not be associated with hypotension, dyspnea, and tachycardia. So once you have a fever and acute reaction, there are various differential diagnoses you should keep in mind. One of them is, of course, bacterial sepsis. So these are the various differential diagnosis. That is, you have to first of all you have to rule out acute hemolytic transfusion reaction and FNHTR, which may also cause an increase in the temperature. Hemolytic transfusion reaction, obviously, there's a hematuria, there is impending doom, loin pain, all of that very common. That's a different topic altogether. But you should keep in mind that it can present as a fever. So acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, even TRALI can also occur with fever and of course bilateral infiltrate on chest X-rays. So what is bacterial contamination? It is a great concern as transfusion transmitted disease. Infectious risk of other diseases has decreased due to better donor testing, but the risk of bacterially contaminated platelet concentrate is almost 1,000 times higher than the combined risk of TTI with the triple H, that is HIV, Hep C, and Hep B. Although the incidence of bacterial sepsis is low, the morbidity and mortality itself is very high. So this was first identified almost 60 years ago in a report that was published in 1941. Since 2004, bacterial contamination screening methods were implemented and it has reduced the transfusion transmitted bacterial infection. FDA reported transfusion related fatality of almost 13% in confirmed or possible transfusion related fatalities. In US, the bacterial screening of platelet implementation caused a 50% reduction in reported reactions. So what are the definitions? According to CDC, it is the infection within 24 hours with no other potential confounding condition exist and a positive culture sample from both patient and blood bank. So you have a positive culture from both patient and blood bank. A British group says that bacterial infection following transfusion with evidence of blood product contamination or infection in the donor. The French group, however, has a very clear definition in which they have divided into definite, probable, and possible causes. So if you can isolate the organism in the blood product and the same organism in the recipient's blood, it is definitive. If organism is present in the blood product but not tested or culture is negative in the recipient's blood, it is negative or probable cause. Possible cause is when the organism or culture is not done, but the culture is positive in the recipient blood and there is a huge clinical suspicion in this. In the order of occurrence of TTBI, platelets are the most important product because they are at room temperature. They have this semi-permeable membrane of the bag which allows exchange of gases, and with gases you can also have some bacteria which may come. So platelets are most importantly uh, affected. Then you have the RBCs also. There are various organisms which are particular to specific product, that is the blood component, that we'll come across. And then there can be also present in plasma or cryoprecipitate. So let's start with the causative organism. So I know these are things which you have to mug up, but an easier way is for red cells, it is Y space. When I say Y space, that's an acronym. Y stands for Yersinia entericulata. Uh, S is Serratia. T is Pseudomonas. A stands for aureus, that is Staphylococcus aureus, Clostridium, and Enterobacter. So Y space for red cell, Platelets, you see there are 5 S's, that is Staphylococcus aureus, Staphylococcus epidermidis, Serratia, Streptococcus, and syphilis causing organism, that is Treponema pallidum. Along with that, you have gram-negative bacilli like Klebsiella and E. coli. Plasma, it is obviously P stands for plasma, and P also stands for two P's, that is Pseudomonas capacia and Pseudomonas aeruginosa. So there are various sources of contamination, right from donor arm derived, donor bacteremia, when the contaminated collection equipment, and blood processing. So if we divide the various sources of contamination, we can divide it into 4 of them, that is donor arm derived, donor bacteremia, contaminated collection equipment, and blood processing. So let's go to donor arm derived. So it is a major source of bacterial contamination, and it is basically because there is uh, inadequate donor arm disinfection, and it is affected by normal skin commensals, that is the coagulase negative staphylococci. So inadequate skin preparation can occur because of organisms like Staphylococcus epidermidis, Staphylococcus aureus, and diphtheroids, and they may be present in the hair follicles or deep-seated sebaceous cyst and all of that, and that can come as the contamination because of the donor arm. So donor bacteremia may occur when the donors may be asymptomatic. Basically, they may be having some chronic low-grade infection or recovery from a bacterial infection which has happened earlier. Or they may be having some transient bacteremia which is undetected as of now. And various organisms are implicated in them. So endogenous organisms are the ones that are particular to the specific area. For example, for gastroenteritis, you have the Yersinia enteroculata and Campylobacter jejuni, which are pertinent there. We have the respiratory infection because of Streptococcus pyogenes. We have the chronic infection like osteomyelitis, syphilis, which may be caused by various organisms like Salmonella, Serratia, and syphilis, obviously because of Treponema pallidum. And you can have after a dental or a medical procedure, which can be because of Staphylococcus aureus. Third is contamination of collecting equipment. It can be both contamination of blood bags, contamination of the apheresis unit that you are using. So all of this is implicated in the uh, organisms like Serratia marcescens, which is commonly implicated organism in the blood bags. It is capable of growth at 4 degrees and 22 degrees, and it derives nutrient from the water-soluble plasticizer and leaches into the aqueous content of the blood bags during storage. Blood processing itself can cause contamination, and this is because the blood bags under stress due to pressing or centrifugation, or sometimes we do manual pressing, and can cause minute lesions in the bag, and this causes portal for entry of bacteria, which becomes easier. Now incorrect function of sometimes sterile connecting device and contaminated water bath is very important, because water bath, you keep many a times you keep your products and the water is not changed, so that can also lead to various organisms which comes and cause bacterial contamination. And the mechanism is bag exterior contaminate at plant. It can be obviously Serratia. During fractionation, it can be Pseudomonas, and during thawing, it can be Burkholderia, Capasian, and other Pseudomonas species. So if we talk about various components, platelets are the highest risk of sepsis and fatality, and common risk of infection due to transfusion of blood. It occurs hours after transfusion. It may go unrecognized. The patient may be asymptomatic, symptomatic, or may cause various morbidity and mortality. Occurs in 1 to 2,000 to 3,000 platelet transfusion, and is the most frequent source of septic transfusion reaction because room temperature promotes bacterial growth. And various organisms are Staphylococcus, E. coli, and other organisms. And it is mostly gram positive, mostly aerobes compared to gram negative organisms. In RBCs, it is various cryophilic organisms which are implicated, like gram negative rods, which actually look for colder environment, and it causes asymptomatic donor bacteremia, occasionally implicated in autologous transfusion as well, or which is highest with the intraoperative blood salvage. So we had already covered this white space. So Yersinia, Staphylococcus, Serratia, Pseudomonas, and other species like Enterobacter are implicated in transfusion transmitted bacterial infection in red blood cells. Basically, they utilize the citrate as a source of iron and therefore can survive in the low temperature. Leukocyte buffy coat depletion prevents outgrowth of Yersinia by removing the WBCs. So there is a case report which has come for FFP being implicated because of the transfusion transmitted bacterial infection in FFP through Burkholderia capacia, which is so even this product is also uh, actually affected by the transfusion transmitted bacterial infection as well. So what are the factors responsible for transfusion reaction? It is the inoculum level that has been transfused, that is the bacterial load that is there, then the nature of the particular organism, how viral, how pathogenic it is, the health of the patient itself. If the patient is a immunocompromised patient or a critically ill ICU patient, children or pregnant women, obviously they are high risk individuals, and the type of antibiotic therapy that has been administered. The various clinical signs and symptoms are there. The first is fever, very important. Now, fever also, you should keep in mind that there should be no pre-existing fever, one, and the fever should be greater than 38.5, or in some books it says 39 degrees Celsius, or an increase of greater than 2 degrees Celsius following transfusion. It may or may not accompany with rigors, tachycardia, systolic BP fall, fever and chills may occur. So, but the most important thing is that the reaction or the fever may occur within minutes, and it is almost like you have a, a, a transfusion crash sort of a things. So fever and chills may occur, and it appearance of symptoms may almost come within 30 minutes. So most cases it is due to gram-negative bacilli, and with gram-negative bacilli, obviously this interval even becomes shorter, and there is a risk of morbidity and mortality. That's why E. coli and Klebsiella are very commonly associated with septic transfusion reaction, and you have to do a culture for it, and but also remember that the culture may not come immediately positive because there is an initial lag phase, and depending upon the bacterial load, the bacteria may reach an exponential phase later on. So therefore septic reaction may occur later, and that is why all cultures should be extended to look for bacterial growth even when the bacterial load is low, to actually go for this exponential phase. Management is like any transfusion reaction. We have to stop the transfusion immediately. We have to resuscitate the patient if required, and collect blood from the opposite arm if you are suspecting a transfusion reaction. So that has to be sent for the culture. Obviously, your routine investigation like DCT, plasma-free hemoglobin, repeat cross-match, typing, clerical errors, all needs to be checked. You have to rule out an acute hemolytic transfusion reaction because fever is one of the very early signs of acute hemolytic transfusion reaction. You have to look for other signs and symptoms of acute hemolytic transfusion reaction, which may also be a differential diagnosis. If there is a high suspicion, we can start with a broad spectrum antibiotics, and combination of vancomycin and a broad spectrum beta-lactam or aminoglycoside will provide coverage of most pathogen. You have to alert the blood bank because you have to recall all the units. You need to even talk to the donor, and whenever you have uh, like a basic protocol, you also do a gram staining and cultures, and all the co-components of the same donation should be quarantined. So the methods for detections include, there are very sensitive methods in which sampling can be performed up to 1 to 2 days. However, there are less sensitive method in which the sampling has to be done within few hours prior to transfusion. Now there are rapid methods that are available which use pH and glucose dipstick, and they detect greater than 10 raised to power 7 colony forming units bacteria and can be performed in seconds as well. So various methods of detection are there, and depending upon in how much time you can detect it and what bacterial concentration you can detect it. So swelling and visual inspection, it requires 10 raised to 8 colony forming units, and it is detected in seconds. Acridine orange or gram stains can be used, and but they require 10 raised to power 5 or 10 raised to power 6 respectively, and can be detected in minutes. Virax PGD or a rapid immunotest detects 10 raised to power 4 bacterial colonies, and less than 1 hour you have the result. And by culture, you take almost negligible or 5 to 10 copies also colony forming units are present, it can detect, and it starts giving the positive results after 12 hours, and actually we have to extend it till the whole unit's life. So it can detect in almost 2 days to 7 days. So visual inspection is it's a prudent quality control measure which we all do. Then there are some assays that lack sensitivity like microscopic examination, endotoxic assays, metabolic changes, microvolume fluorometry, and some are available assays like culture, like a normal culture, routine culture, or you can have an automated blood culture system. Of course, there are pros and cons of each. And then there are some assays which are in development like dielectrophoresis, flow cytometry, bacterial cell wall detection, and molecular techniques. So if you see detection of contamination, visual inspection, we all have to see. We have to see for in platelets, we have to see the swelling, and in red cell, you have to see if there is a dark color when compared to the sterile units. And swelling, we all know it detects levels of greater than 10 raised to power 7, that is 10 raised to power 8 colony forming unit per ml in platelets. And swelling is basically a fish in a swarm appearance, and which you have to see against the light. And it is pearly appearance of a platelet that occurs when unit is inverted. Now, this is caused by a local increase in the turbidity when asymmetric platelets align with fluid flow. Now, platelets cease to swell when there is high level of bacteremia because it causes declining pH, and the unit causes asymmetric platelets to become more spherical. So, advantages, it is non-invasive, and this is an example where a pooled platelet is affected with serratia, and there is a large fibrinous coagulum clinging to the inlet. So how do you detect other methods? There are gram staining through microscopic examination. There's a dipstick method, fluorescent based method, but this method's sensitivity is all lower than that of the culture. There is a method available called endotoxin assay, in which also known as bacterial endotoxin test BET or Limulus immunocyte lysate test. In vitro assay it is, and it is used to detect the quantify the bacterial endotoxin. Depending on the color, you can actually tell the concentration of the endotoxin level. Basically, an endotoxin combines with a drug conjugated nanoparticles, and when uh, uh, they have a combination that is detected by the use of a color. So that can be checked like a normal rapid card. And depending upon the color, you can also predict the endotoxin levels. There is automated culture levels, like you have a biomuro Bactalert system, which is present in our hospital as well, or you can have a Paul bacterial detection system or a Paul BDS, which have different principles for the same. So Bactalert system, it's a colorimetric technology to detect carbon dioxide producing by the growing microscope, which is then visualized as a color change on a sensor at the bottom of the culture bottle. So all culture bottle have a sensor at the bottom, and these culture bottle which contains aerobic and anaerobic growth bacteria, the growth media, are aseptically inoculated by a manufacturer recommended volume of the platelet. Generally it is 4 ml. As bacteria grow in the culture, uh, during incubation at 37 degree, carbon dioxide is released because the microorganism will release the carbon dioxide, and this causes a reduction in the culture media pH. pH sensitive disc at the bottom of the culture bottle changes color, which is detected by alteration of the reflected light on the disc. So this is the reflected light, and you can see on the disc, that is the photodiode, you can see there is a color change, and this is rapid result, and it has a alarm or a beep system also. If anything comes positive, depending on whatever hours it is, it gives you an alert that okay, this culture bottle or culture media is positive. We have the Paul BDS system, which is based on the measurement of reduced oxygen level rather than the carbon dioxide in contaminated platelet components caused by the microbial oxygen consumption during proliferation. It is a closed system. A small unit of is filtered to remove leukocyte and platelets without removing large number of bacteria. The pouch contains a dissolvable tablet of sodium polyanethol sulfonate, and it minimizes the natural inhibitor. The system compares the level of a pre-programmed threshold value. So this is also a very unique system which utilizes the reduced oxygen level rather than carbon dioxide levels. So Varex PGD, I've already talked about. It is a rapid method. It is a technology which utilizes the conserved bacterial antigen immunoassay. Here you measure dactylate, you measure carbon dioxide, and Paul EBDS, you measure the oxygen. The sample value may differ depending upon each test, and they have all a very good clinical specificity. Varex PGD is 99.7, Bactalert 99.2 to 99.8, and Paul EBDS is 99%. So disadvantages of automated culture method: blood cell yields, the function, circulatory survival may present a toxicity risk to recipient blood bank personal environment because it's an automated thing. And implementation of pathogen detection method is also expected to cost many times more than the bacterial detection method. So there are pathogen detection methods as well available. There are four methods if you see. Ametocillin, which is a synthetic sorolin which exposed to ultraviolet light, causes a permanent crosslink in the bacterial and viral nucleic acid chain and prevent pathogen replication. It is used for FFP and platelets. Similarly, you have the mirasol or the riboflavin, which is used in platelet. Then there is S303, which is can disrupt pathogen RNA or DNA, and inactin, which binds to nucleic acid, resulting in the inhibition of pathogen replication. So if culture remain negative after 24 hours, platelet is released for transfusion, and there are various disadvantages of culture methods also, because it causes product loss, delay in the product because it takes time to have the result depending on bacteremia, and false negative result may occur, cost of course, and logistical problems associated with culture methods. So prophylactically, what are the mitigation strategies we can do? We can prepare the arm has to be prepared very carefully, and it has to be disinfected. The preferred disinfected solution is 2% chlorhexidine in 70% isopropyl alcohol. You can have bactericidal treatments like UV exposure or sorolin we have talked about. Water bath, very important, has to be disinfected frequently. There can be overlap. Visual inspection of blood components before use, dark purple or black discoloration, or you have to see swelling, whatever. Your visual inspection has to be clear. And sometimes increasing the culture volume also shows the doubling of the volume of the blood culture results in a 54% relative increase in the culture sensitivity. Then proper donor screening, very important. Sample diversion pouch, it reduces the amount of contamination. Then apheresis versus RDP, you always prefer apheresis unit. Reduce storage time, the more they are stored, then storage lesion may occur and there can be bacterial contamination. And leukoreduction itself removes phagocytized bacteria along with leukocyte. So coming back to the transfusion reaction, so whenever you have an acute transfusion reaction with fever, chills, hypotension, which happens within minutes, you have to look for transfusion transmitted bacterial infection. You have to go for a culture. You have to have the same organism detected in the patient and the blood component. And this may happen within minutes and may take 24 hours. But if you compare the fever between all the transfusion reaction, you can see that transfusion reaction immediately occurs in a acute hemolytic transfusion reaction or in cases of septic reaction. Whereas if you see FNHTR, it may take some time, and TRALI takes a longer time than all three of them. So fever at what point and a good history is very important, as which will point towards what is your acute transfusion reaction here. So this is a study that has been done from India, in which they had detected, they had actually evaluated 3,903 cases in which uh, the adverse reaction was reported in 18 patients, 7 females, 11 males, and the implicated blood product here was red cells in 14 patients, apheresis in one patient, and other components in one patient. So this is the organism that was most commonly isolated was E. coli, Klebsiella, and Staphylococcus epidermidis. Thing to note here is E. coli, Klebsiella, and Staphylococcal epidermidis are the ones which are capable of causing septic transfusion reaction like a fatal septal. So these three are very important organisms which you should remember. So this is a short 2021 annual report, and this is the outcome of confirmed TTI incident and implicated components by infection in UK. And you can see that mostly the bacteremia has in red cells, pooled platelets, and apheresis platelets, and most commonly in the pooled platelets. This is our paper on evaluation of bacterial inactivation in random donor platelets, and we use an intercept blood system for pathogen reduction technology. This is from Serious Corporation in America, and basically what we did was we had single donor platelets and random donor platelets were prepared with prior consent of the donor. Both units were deliberately contaminated by a stable stock of Staphylococcus aureus and E. coli respectively. And after that, post-illumination, test samples did not result in any bacterial growth. A complete reduction of 6 log was achieved, and the intercept technology was very effective in actually dealing with the uh, pathogen reduction. So now a small brainstormer before we end. Now I think all of you should know the answer of this. That is, which of the following product is most commonly associated with fatalities due to septic transfusion reaction? I think you know the answer. And the second question is, which of the following organism is most likely to cause the symptoms seen after transfusion of platelets itself? Remember platelets, 5S. So I don't see there is a problem here as well. So these are the answers. And if there are any other questions which are associated with this topic or any other topic which you want us to take, please inform us and we'll be happy to take. Thank you so much and happy learning.